Yeah, that's perfect opportunity to do it because no, she's working. Yes. She went for because that was and I take a while. You know, you just get
Good morning, everyone. Hello and welcome to the 2023 Community Health Navigator Forum. Can everyone hear me okay? Great, okay. So I'm Associate Professor Fiona Haig. I'm the Director of the Health Equity Research Development Unit at Sydney Local Health District, and I'm going to be your Master of Ceremonies for the day. Today we're gathered on the unceded lands of the Gadigal people of the Eora Nation, and what a stunning day. I travelled down this morning from Durrag and Gundagara country up in the Blue Mountains, and although it was a painfully early start, it was a beautiful morning watching the sun rise and travelling down the mountain. I would like to pay my respects to elders of these lands, both past and present, and extend that respect to all Aboriginal and Torres Strait Island colleagues, presenters and guests who are with us here today. For those of you who are in the room with us, in this incredibly nice theatre, a few housekeeping notes. Refreshments and a light lunch will be later served on the tables just outside the theatre there, so please help yourselves. So we have presenters in person and online today. Hopefully everything will go well. If not, just be patient while we sort things out. We've got a lot today. We've got a lot of people sharing a lot of experiences, which means that we're going to have to be reasonably tight on timekeeping. So speakers, we've got a little bell that we're going to ring when it's kind of time for you to wrap up. So apologies in advance, but you will hear it if you do go over time. Yep, there it is. So for the online presenters, you are in control, so you'll need to share your slides as you do your presentation. And yeah, if there are any problems, we'll try and sort them out at that time. So let's begin. I'd now like to invite Brendan Kieran from the Metropolitan Local Aboriginal Land Council to welcome us to country. Thank you, Brendan.
Thank you and good morning, everyone. My name is Brendan. I'm a cultural representative and cultural educator for Metropolitan Local Aboriginal Land Council. And our role, for those of you that don't know about our Aboriginal Land Councils, under the Land Rights Act, our land councils are the cultural authority, the guardians and custodians of land within our boundaries. And I'm here this morning to welcome you to country. And there's two things I'd just like to say very quickly about a welcome to country. A welcome to country is not a welcome to Australia. A welcome to country is a welcome to the lands that you're gathered on. And the other one is a welcome to country is not something that we have come up with to cater for white people. Welcome to country ceremony is a ceremony. It's disrespectful for Aboriginal people, for my people, disrespectful to walk on each other's lands unless we're welcomed on land. And there are many reasons for being welcomed on lands. It's no different than when you welcome someone to your house. We need to know where the toilets are. We need to know where the water holes are that we can and cannot drink from. We need to know where the sacred sites are that we can and cannot visit. And there are many other things that fall off the back of being welcome to country. So this is our welcome to country. We've been doing it since the beginning of time because that's how long we've been here for. We've been here for 250,000 years plus BC, and the BC stands for before Cook. It gives me great honour to perform this ceremony, and the lands you're gathered on here traditionally belong to the grass tree people, the Gadigal. Gadi means grass tree, Gal means people. And the Gadigal are one of 29 tribes that make up what we call the Eora Nation. And the boundaries for the Eora Nation start from the ocean, and they're surrounded by three of Australia's most beautiful rivers. We've got the Hawkesbury River, we've got the Nepean River and the Georges River. In between those three mighty and beautiful rivers, there are 29 tribes. that make up the Eora Nation, and the name of the tribe you gathered on here this morning is Gadigal. I'll share a very brief history of country, part of country, and my history connecting the country. I'm the second generation of my family that's part of the kidnapped generation, not stolen generation. We weren't stolen, we were kidnapped. My mother was taken at the age of 5, locked up in a jail for 2 weeks, put on a train and transported to training camp, Cootamundra Girls' Home. My uncles went to Kinchela Boys, and the babies of the family went to Bomaderry at Wollongong. And these places were training camps. They were taught and trained how to be servants and slaves. They were sent out to white families to work, never got paid a cent for the work they did, and they were punished for speaking their own language and practicing their culture. Just to give you a little bit of insight into one of these places, Cootamundra Girls' Home, nearly 40% of all women that went through that home became pregnant. 40% being sent out to white families to work. I've got letters at home that Mum wrote to the then Minister of the Aborigines Protection Board. I never met my mother. Never met my mum. All I've got is letters and a photo. Mum had to write letters to the minister begging for money to have a haircut, begging for money to buy a new pair of shoes, begging for money for a train ticket, begging for money. And I'm not talking 2 or 3 generations down. I'm talking, this is my mother. 7 years ago, I found Mum's grave. I was born in 1971 at Crown Street Women's Hospital. That's the last place I ever felt my mother's touch, hospital. When I found Mum's grave, I found I'm one of 10 siblings. All of us taken. And as I mentioned earlier, the second generation of family. I've met 3 brothers and 1 sister. We haven't spoken for 5 years. You can't have a relationship. There's so much trauma and abuse in my family. And my story is no different than a lot of my countrymen's stories. There's no traditional owners left within the boundaries of the Eora. No traditional owners left. The definition of traditional owner is you've got to have an ongoing, continual connection. And unfortunately, that was severed the day Cook landed. In less than 50 years, 80% of our people was wiped out. Biggest killer was disease. It didn't take long for the English to realise that smallpox and the flu were so devastating. They deliberately handing out infected clothing and blankets and poisoning our waters. They were using chemical warfare. The second wave of the invasion brought what I call the land grab. And with the land grab came the massacres and the slaughters. I had 500 of my family members, men, women and children, that were all slaughtered just over the river for their cattle to drink. All slaughtered so they could have the water for their cows to drink. But these are stories. This is a brief history relating to country. And my history is your history. I live here, you live here, and vice versa. I can tell you the history of every race in this country. Tell you the history of every race. How many of those races can say that about us? Learn the history of country. Learn the history of country. It gives me great honour to welcome you here this morning to the lands of the Grass Street people. On behalf of those Gadigal ancestors, because we believe their spirit is still in the lands and the waters. On behalf of Metropolitan Aboriginal Land Council as the cultural authority on these lands, it gives me great honour to welcome you here this morning. Welcome to Gadigal country. Just before I run, we all know we've just had the referendum vote. For me personally, it took me back to 20 years. 20 years ago, it took me back to a place that I thought I'd never go back to again. It took me a very long time to walk around with my head up high in this country. Over the last week, I've noticed my head's down a little bit. Head's down a little bit. The worst thing about it is my children are going through the same racial abuse that I went through as a child. So it's brought a lot of stuff up. There's one positive thing I got out of the referendum. And I said to my wife, we were looking at the numbers come in, and I said to my wife, well, there's no way I'll be moving to Queensland. No way I'll be moving to Queensland. But has what we've done over the last 100 years been a waste of time? All the protests, all the talking, has it been a waste of time? We need to keep the momentum going. We did have a lot of supporters. We need to keep that momentum going. And I feel as though it's time for action. Time for action now. We've spoken enough. I just thought I'd share that as well. I struggled the very next day to do ceremony, welcome to country ceremony. I thought, what for? What's the point? But I was blessed enough. My ancestors always throw curveballs, and the curveball I first copped on the Sunday was I did an event for the wheelchair-powered football, international, and I was asked to stay. I never stay at events. I was asked to stay. And when I watched these people come out in their wheelchairs and the issues that they were going through, for me, that was my grounding moment. Grounding moment. So thank you for having me. Welcome to Gadigal country, always an honour. I'd love to stay, but unfortunately, I have to go and pay a white man by the name of Wilson for parking on my own land. And he's not cheap either. I pay my respects to my elders, past, present and emerging. And I extend those respects to my non-Indigenous brothers and sisters as well. The only thing that makes us different is our language. The only thing that makes us different. Thank you for having me. Welcome to Gadigal country. Thank you.
Thank you, Brendan, for welcoming us to country and sharing such personal experiences and also leaving us with a call to action, which I think is really good for us to kind of keep in mind throughout the day. So, as I mentioned, I'm the Director of the Health Equity Research Development Unit, HERDU, and for those of you who don't know HERDU, we're a partnership between Sydney Local Health District and the University of New South Wales. And I think today, a lot of what we're doing is really celebrating and sharing stories about other partnerships and programs and organisations who are working together around this area of community health navigators. So today our forum is hosted in partnership with Sydney Local Health District, the University of New South Wales Centre for Primary Healthcare and Equity, and Central and Eastern Sydney Primary Healthcare Network. So I'd like to take this opportunity to thank all of those organisations for putting this forum together and investing in the many different kinds of community health navigator programs, roles, initiatives, projects that we'll be talking about today. So I'd now like to introduce Luanne Blunden, the Executive Director of Clinical Service Integration and Population Health at Sydney Local Health District, to say a few opening remarks on behalf of the District's Chief Executive, Dr. Teresa Anderson, who unfortunately couldn't make it to today's forum. She sends her deepest apologies and is looking forward to watching the recorded version online. Thanks, Luanne.
So good morning, everyone. And that was a sobering welcome to country and very timely. We as an executive and board members have recently had the visit by the Kinchela Boys mobile van. You don't go anywhere on the bus, but you hear the whole storytelling about Kinchela Boys. If your organisation hasn't done it or you haven't had the chance to do it, I really do recommend it. It is just as sobering as some of the snapshots and little things you just heard about the history of our Aboriginal population. So good morning and welcome to the Community Health Forum. And thank you, Brendan. It was as I said, a very sobering, warm welcome to country. I'd also like to acknowledge the traditional owners of the land that we're standing on, which is the Gadigal people of the Great Eora Nation, elders past, present and emerging, and extend my respects to all Aboriginal people who are here in person or online. So as Fiona said, I'm Luann Blunden. I'm the Executive Director for Clinical Services Integration and Population Health for the district, and I have the pleasure of having all of those wonderful services that work within the community, and also encourage integration between those services that work in the community and our very important acute services and subacute services. As Fiona said, Dr. Anderson apologises for not being here today. She's been called into the ministry, but she has come back from leave refreshed, invigorated and just full of ideas. And she recommends it to all of you to get a bit of a break and refresh and think about all those initiatives that we could be doing within health. So I'm very pleased to be here today. We showcase some of the important work which is happening in this space. And as we come together to share our hopes and goals for the future, I hope you all particularly enjoy meeting together, physically together. There's nothing like it, is it, in person? I'd like to acknowledge our partner organisations for today's forum. As we've heard from Fiona, the University of New South Wales, the Centre for Primary Healthcare the Centre for Primary Healthcare and Equity from the University of New South Wales, and we've had a very long partnership with the Centre, the Central and Eastern Sydney Primary Healthcare Network, and we certainly have a very strong partnership with them as well. And Brendan and Natalie will be here with you today. We have a strong partnership and commitment to ensuring our community, consumers, patients and their families receive the best possible care. And we are holding this forum today to celebrate some of the ways we do that and share our mutual strengths, challenges and goals. Some of you may have been here in, I think it was January 2020, when Liz and Mark were trapped in the fires. Where were you? Which island? Everybody remembers the fires. Kangaroo Island, that's right, and they were unable to make it. But we had a very good forum where we first discussed the opportunities for community health workers and educational programs. We also welcome representatives from other countries, universities, local health districts, health services and providers who have travelled from far and wide to join us today. I'd also like to welcome many community health navigators who are here, consumer reps and community members, and a big welcome to all of you who are online with us. For those who don't know, I've had the privilege of working in the public health system for over 40 years in a variety of roles. I commenced initially as a radiographer and then trained as a physiotherapist and then went into planning and finally into senior management. But I've had roles all over the state, and I just am so privileged to have worked in the public health system. It's a great place to work, and it also gives you an amazing opportunity to work in many roles if you're keen to do that. More recently, I've seen and experienced the impacts and the potential that community health navigators have, especially working with some of our most vulnerable communities within Sydney Local Health District. Community health navigator roles continue to be an integral part of the health system and are an essential tool to bridge the gap between healthcare providers and patients in community. I'm probably preaching to the converted here, but for all of you or some of you that might be learning about community health navigators, they're extremely important. Sydney Local Health District, a little bit about our region, is rich in cultural and social diversity. We have more than half of our population speaking a language other than English at home. We have high numbers of refugees, asylum seekers and humanitarian entrants, a very significant Aboriginal population, especially in Redfern, Waterloo area, the City of Sydney and in Marrickville. Our proud lesbian, gay, bisexual, transgender, intersex and queer community. We've got a number of our suburbs which have the highest proportion of same-sex couples in Australia. A significant stock of social housing with large complexes in Waterloo, Redfern and Riverwood. A large population of people who are homeless and rough sleeping. 40% of the New South Wales boarding houses are actually within our local health district. The district's patient and family-centred approach to delivering healthcare for our diverse community in our community provides a sound framework for our decision-making and day-to-day business. We have regular opportunities for our community to engage with us and to make decisions about their care. We have joined together with other government agencies and non-government organisations to support those who are most vulnerable in our community, including the homeless, the elderly and people living with a disability, and community health navigators, which are just one of the many different ways we connect and collaborate with our communities to deliver accessible, inclusive, culturally appropriate and holistic healthcare services. I certainly can't underestimate our partnerships with our government agencies and non-government agencies. And as we all saw, that strength of partnership was tested during COVID, but it certainly stood the test of time, and it's grown even more now. Community health navigators or workers by a variety of names in Australia include community educators, bilingual community educators, care navigators, Aboriginal health workers, co-workers, peer workers, cultural support workers, link workers and extend workers. And let me tell you, they're all on different health awards as well. Although they may have different names, many of the roles have strong commonalities, such as they work with both individuals and communities. They are often trusted members of and have a deep understanding of the community, which enables them to function as a link between the health services and the community. They build individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities. These activities could be outreach programs, community education sessions, informal counselling, social support and advocacies. So the commonalities and the many unique nuances and differences of the navigator roles all aim to achieve the same goal, which is, many of you know, improving access to care and health outcomes, particularly for the disadvantaged groups. A range of reviews have identified that community health navigators and workers have positive impacts on a patient's access to healthcare and health behaviours. And there's also growing evidence that they have an important role in improving the health of individuals and communities and reducing health inequities. Back in December 2020, and that was after we'd had the other forum, the Health Equity Research and Development Unit, we call HERDU, which, as Fiona said, is a partnership between our district and UNSW, conducted a scoping audit and a mapping of the different community health navigator roles within our district. Excuse me. The process found the district had just over 43 full-time equivalent roles that could be constituted as navigator roles. Since the initial findings of this audit, the amount of community health navigator roles in this district in particular has grown and it continues to grow. To name just a few, there is now over 180 bilingual staff across 30 priority languages in our district's cultural support program. There's over 10 peer support workers and also the Waterloo Healthy Living Link Worker, which was commenced after we had an approach from Counterpoint, which is an NGO in Waterloo, and also we'd had community forums with the Waterloo community. And they strongly wanted someone to help them navigate the system and to link them to health services. Today we'll be celebrating and showcasing existing initiatives which are happening locally and globally. We'll hear about examples from Canada, New Zealand and across Australia. There'll be facilitated conversations and presentations which will focus on the strengths, challenges and future hopes of community navigator roles. And there will also be a short series of presentations from our local health district staff, which will highlight the different types of navigator roles and the current work that's happening in their respective fields. And finally, we'll all come together for a panel discussion and a Q&A session on what we all hope for the future and how we'll get there. So as we get started with the presentations and throughout the day, I do invite you to keep in the back of your mind that today is about acknowledging our strengths, mutual challenges, and that we should always be looking for opportunities to make sure that our services reflect the diversity of each of our communities. We need to keep working to ensure everyone is able to be heard and supported. So I really do hope that you enjoy today and meeting new people. So thank you very much. And I now would like to hand over to Miss Natalie Hanson, who is the Chief Executive Officer of the Central and Eastern Sydney Primary Health Network. And Natalie is going to present to us about the need to support and invest in community health worker navigation programs. Thank you, Natalie.
All right. Good morning, everyone. I just made it here this morning. Nothing like a little bit of anxiety before you have to speak. Anyway, I'd like to begin by acknowledging the traditional owners of the land that we're all meeting on today, the Gadigal people of the Eora Nation, and I think there's people joining online as well. I'd like to pay my respects to them and also acknowledge Aboriginal people who are here with us today. So I just wanted to start with this image, which I hope you can see here within the room. It sets the scene for why we need health navigators and is taken from research by Geraldine McDonald, who did a Churchill Fellowship around patient navigation in cancer care. I think the image conveys how confusing and frightening cancer care can be. Patients describe it as like being on a speeding train without a ticket and not knowing where or how to get off. And I think this is just one example of how people who are diagnosed with a chronic condition can find our whole health system very overwhelming. And that's where I think the community health navigators really play a crucial role. So I'm going to take you through some bit more detail of the case for them. So these are the kind of key points why we need navigation support. Healthcare is increasingly complex due to the specialisation and complexity of health interventions, the increasing number of long-term conditions, and also multimorbidities. So people have more than one health condition. These are compounded by socioeconomic disparities, diversity of culture and language, individual behaviour, and the social and physical environment. So all those factors add to the complexity of care. In addition, the health system in Australia is very complex and it reflects the funding by multiple levels of government, the Australian government, the state and territory governments, as well as non-government funders, private health insurers and individuals. So as a result of increased complexity of health conditions and the nature of the health sector, this increases the difficulty in navigating the health system. It places demands on patients to have really high health literacy, which often they don't have, and it makes it especially difficult for disadvantaged and vulnerable population groups. And this can affect the ability for patient-centred care and self-management. Finally, we all know that the capacity of primary health care at the moment is not great. There are major workforce shortages in rural and remote areas, but also in urban areas, and they're predicted to worsen. So this reduces the capacity of the primary healthcare workforce to offer that support to people when they have got a complex condition, to spend the time with them, to explain what the next steps are and what they need to do. And our funding models as well don't really support complex care. They're very episode-based at the moment. And hopefully with My Medicare and some of the changes that are coming into place, that will change. But at the moment, they're still very episodic-based. There's also evidence for inverse care provision, especially for Aboriginal and Torres Strait Islander people, those living in remote areas and people from low socioeconomic backgrounds. So they're not receiving the level of care we would be expecting they would. And community health navigators can help address this. . 'Cause Sorry, I'm not quite sure how this thing works. Okay. So as Luann, I think I caught you say that they have multiple different names. Community health navigators, the role is not new. I think they started being used in the early 1960s in the US, and they've served lots of different populations and provided a range of health and social services. I think the key distinction between navigators, like community health navigators and other navigators that we might have in services, is that they're not clinicians. Today we can find community health navigators in many countries in a wide spectrum of settings, such as community organisations, health departments, churches, schools, clinics and hospitals. And their roles include providing outreach from services, education and behavioural counselling, identifying and addressing barriers to accessing care, providing navigation support and follow-up care, and acting as a bridge between consumers and health systems. In Australia, we have a really long history of Aboriginal health workers and peer workers doing this kind of work. And more recently, we've started funding these kind of positions in aged care within this region. A recent example is Care Finders, where they assist people to navigate the aged care system. So this slide here is taken from an American model of care navigators for people who are HIV positive. Interesting study, and it highlights the value of care navigators to three different groups of patients. Firstly, those who have been newly diagnosed, confused about what to do next. Then those who may have been diagnosed for a while but have stopped really engaging in care. They're not attending their appointments, or they're not following everything that they're meant to be doing. We all know what that's like. And then the third group is assisting patients who are referred to other services, because usually when you've got a complex condition, you'll be referred to multiple different services, and that's where it becomes more challenging, how to sort out the appointments, the transport and all that kind of thing. Now, moving on to the effectiveness, there's some evidence for the impact of community health navigators on health service use, meaning that they decrease the use of secondary and tertiary care services, especially emergency departments, and they reduce hospital admissions. And similarly, there is evidence of improved quality of life as a result of having care navigators involved. Now, there's also evidence overseas for their ability to improve access to care, including preventive care, such as smoking cessation and cancer screening, and to improve continuity of primary care. They have supported patients to better self-manage their chronic conditions, resulting in better control of diabetes and cardiovascular disease, and improved satisfaction with care. Evaluation suggests that the use of skilled community health navigators is a cost-effective and worthwhile investment in health resources, and most of the return is associated with reductions in hospitalisation. On this slide, I've really tried to highlight some of the key challenges in implementing a community navigator program. One of these is scepticism or negative attitudes of other health staff about community navigators, their role and their competencies. Another is the lack of standards for selection of community navigators, training, scope of practice, what their roles are, their responsibilities, their workload, how they're reimbursed, and what outcomes we're measuring. And also there's a lack of financial reimbursement in many cases for the services provided, and often the funding is not long-term. It's always trying hard to find bits and pieces of funding to keep this work going, so it's not very secure employment. I'll now talk a little bit about training and supervision of community navigators, because this is really crucial. And this training is not in clinical care, but rather in working with patients to address barriers to care. And such training includes information maybe on the specific diseases and screening that they're assisting patients with, how to do motivational interviewing, communication skills, and they really need supervision and support. And we'll be hearing about that example later in the day, I'm sure, from people who are actively doing this. But especially if the model is to be sustained in the long term, it's really important that good supervision is provided and to avoid burnout of the navigators. So finally, why is Central and Eastern Sydney Primary Health Network interested in community navigators? Well, firstly, we have a really diverse population in this region. Many people speak languages other than English and are unfamiliar with the health system. We also have workforce shortages in general practice and allied health, and they're expected to worsen. So we see community health navigators as a way to support the integration of care, which is one of our key goals as a primary health network. We also see them as an important way to improve access to care. In our region, we have co-funded some pilots of community navigators in general practice. We're about to roll this out more widely with new funding we're due to receive. And our Care Finders program in aged care for vulnerable older people is essentially a community navigator program. So that reaches the end of my little presentation. I hope that's given you a bit of a sense of what the argument for community health navigators is. Thank you.
Thank you. I think that set the scene really well, because I think today is it's partly about sort of sharing experiences, but it's also about thinking kind of like, what do we need to do to really sustain and support this workforce? You know, I think we've got lots of evidence now saying they're a good thing, they're useful. So it's kind of that next step that we need to be thinking about, like, how do we embed, how do we sustain? And I think that really nicely sort of set the scene for today. So now we're going to move on to hearing from international and sort of national examples of community health navigator programs. Some of these presentations will be delivered online, some of them in person on the chairs there. So first of all, I'd like to introduce Associate Professor Simone Daru. I'm sorry, Simone, I didn't have a chance to check the pronunciation of your surname before, so you might want to reintroduce yourself with the correct pronunciation. Simone's from the Department of Family Medicine at the University of Ottawa. She's joining us online, all the way from Canada. Not sure what time of day it is there. And Simone will be presenting on access to resources in the Community Project Canada. Welcome, Simone. Are you there and are you able to see your slides?
Yes, yes.
Great.
And you pronounce my name just fine, so it's all good. Okay, are you seeing my slides okay? The main slide?
We are seeing the slide. Yep.
Yeah, like it's taking the full board. Okay, I'm just going to put my timer on. Thank you for inviting me. I worked with the two Dr. Harris and a few years ago, and I so much enjoyed that collaboration. So I'm happy to continue to collaborate and share our experience here. So I'm going to talk to you about a social prescribing model called Access to Resources in the Community. So we began with the problem being that patients were not accessing a lot of resources that were available to them. And why was that? So we conducted some consultations with patients, primary care providers, and then we developed a partnership. So one of those collaborative partnerships that helped us establish the approach we should be taking. And that partnership decided that we were going to implement navigation services, which later we realized they were really more of a social prescribing service. So let me get that described here. So essentially, ARC links primary care and community sectors. The primary care providers refer patients that have health and social needs without knowing what resources are available to them, then the navigator identifies the service best suited for them, helps them overcome barriers and reach the service that they need. They report back to the provider for the continuity of information. We have a toolkit available we've shared for setting up social prescribing in different regions. Just to give you an idea of the type of needs that our program has addressed, most commonly it's health related, because remember, these are patients who are referred to us by their primary care provider. We were told they're never going to refer to for social needs. They're just not really looking at that. Well, it turns out that no, without a lot of prompting, they, knew their patients, and 26% of the referrals were for social needs. But of course, healthy behavior was another very important one. Okay, so what are the important features of this program? So the information I'm going to show you now, I'm going to go over quite quickly because it's all available online, and I'm going to show you the guides that are available for you to take a look at if you wanted to look into this some more. But I'm just going to tell you some of the key features I think work. First, we bring some changes to the practices that are intended to better engage the primary care providers and their patients in acting on their needs. So we identify a champion whom we continue collaborating. We orient the practice members on the social determinants of health and the resources available to them. We train them on the processes. We put up promotional material in the practice to increase awareness for the patient and encourage them to ask a question. We establish a referral mechanism, which now in Canada, we've got an OCEAN approach, which is a confidential way. So we had used fax, but now we've evolved, and we're trying to, our ministry's motto is ask the facts. And the navigator also had a space within the practice to meet their patients, at least for the first time, to build that trust. We conducted rapid cycle evaluation to make sure that the practice was comfortable, that they didn't, and if there was something that needed to be changed, then we addressed that. So what did we ask them to do? Identify the patient that needed help, engage them in self-care, and then refer them. So there's a guide for practice setup. It's our first guide. Okay. Who is the navigator? So again, as we were just told this morning, it's a non-clinical person. Patient-centered approach is very important. They address any health and social needs. So we wanted them to be the point of entry for anybody, regardless of what patient group type they might be, or what social community they might belong to, or what type of needs they might have. It's one single point of entry, and to facilitate the work to those who are referring to us. They're highly trained, and I'll tell you about that in a sec, in motivational interview, active listening, and a lot of the approaches intended to engage people in self-care. We provided longitudinal support, and here's a little summary of the type of support that we provided. So it wasn't just informational, it was emotional and what we call instrumental to help overcome barriers that they had. So the training is, we have a guide, so I'm actually, whoops. So here we go. No, I'll bring the guide up a little in a sec. Okay, so we trained them to develop the key competencies that they needed to have. I'm just going to move that up a sec here. Okay, one more. Here we go. Their function was to establish a relationship with the individual, to understand their barriers, expectations, priorities, and how ready they were. It was important for them to understand their readiness, and then to deliver the support to help them overcome the barriers and access the service. And they reported back to the primary care providers. They were supported, and I think that's an important feature. They were supported in their functions with guides, scripts, and they had standardized data collection tools that they had to fill. So, oh yeah, so that was done. So they reflected some of the functions they had to do. So we have a guide for the navigation processes, and we also have a guide for the training. Okay. We undertook a feasibility study that demonstrated that implementing ARC in primary care practices is feasible, it's acceptable, it was highly valued by providers and patients. And so, especially in the non-interprofessional practice, we didn't have the kind of support that the interprofessional did. So then we undertook a randomized controlled trial to understand. So this was a quite resource intensive navigation model. So we wanted to understand the benefits that could be achieved by having this intensive program. So we compared it to an existing provincial, there's a national program. It's in the US as well. It's called 211. You actually dial 211 to get the services. So they only get incoming calls, unlike us, which we could call the patient, and it's almost exclusively a single encounter. So we really not comparing apple to apples, and we knew that. So maybe one of the things that I want to point out is, so 71% of those referred joined, and 27% were lost to follow-up. Very briefly, patient experience, ARC is in red, 211 is in blue. Patients had a strong preference for the ARC, both in terms of effectiveness, their patient-centered approach, and their overall experience. So what about the providers? Maybe what I want to point out is that having the Navigator in-house incited them. No, sorry, they're not in-house, available to their patients. So one Navigator was outside the practice and served a number of patients, incited them to make their referrals. It increased their knowledge of the resources available. And again, it did not interfere with their work. What was the added advantage in terms of benefits? ARC was superior to 211 by 40% higher usage. And it didn't matter how you looked at it, different sensitivity analysis, it was about the same thing anyway. ARC reduced inequities, and I don't have a lot of time to go over this, but essentially it reduced the gap in access across education level. It better supported people who were more socially complex, who had a number of needs, and it improved access to language concordance services. I'm going to skip this here. So what are our conclusions and recommendation? I didn't talk about the first conclusion here, so I'm going to skip that here. But it obviously offers benefits over 211. It likely improves equity in access, and our recommendation was to improve the efficiency of the program because it's quite resource intensive. So we wanted to do a two-tier navigation service where those who are less complex can get don't need to go through the entire level of support. And we wanted to integrate it into an existing service for scalability and sustainability. We also want to improve the identification of patients because I think we've got a lot of referrals, but I think there's much more need than we saw. So the last slide is that we've actually entered a partnership with our one of the divisions of the Ontario 211 that's called Community Care. They're a not-for-profit organization. We had a similar vision, and so we're going to build on their standardized. We're going to build and bring them standardized tools for training and processes to enhance fidelity, a rigorous evaluation, and they're providing the infrastructure and technological innovations to bring the ARC model available to a larger population. We're planning a trial in 2024. I think that's 10 minutes.
Thank you so much, Simone. You can't see everyone in
Pleasure.
the audience here, but they were very engaged and interested.
Oh, good.
And I really like the way that you were able with your research to sort of unpack some of the different ways that this model works. And it was really interesting to hear that actually it was showing that you were reducing the gap. So not just
Mhm.
not just kind of having positive impacts, but actually acting on equity. That was really great to see. Yeah, so now I'd like to move on to our next presentation. I'm very excited about this because it's some Kiwis, always a good thing. So it's co-presented by Professor Fiona, also Fiona, another good thing, by Professor Fiona Doolan-Noble from Goldfields University Department of Rural Health at Kalgoorlie campus, Curtin University, Australia. And she is co-presenting today with Ms. Danielle Dawson, Senior Lay Health Navigator at West Coast Primary Health Organisation in New Zealand, and they'll be presenting on health navigators in New Zealand. So welcome, Fiona and Danielle. Are you there and able to share your, yep, slides have been shared? That's great.
Can you see it? Can you see the slide, Fiona? Is it up?
Yes, they're looking good.
Awesome. Okay, thank you. Well, hello everyone. So I'm in Kalgoorlie, but only recently. So I moved over from New Zealand about 6 months ago. I'd like to thank the organisers for inviting Danielle and I to present here. It's our third time on presenting on this programme, so we're some of the stuff might be familiar to some of you, but we hope we're adding some new information. So just before we start, I'd like to acknowledge the traditional custodians of the country that the UDRH is on, the Aboriginal people of our many lands where we work, their language groups, and recognise their continuing connection to land, sea, culture and community. And we want to pay our respects to elders past, present and emerging. So what we're going to cover today is I'm going to briefly discuss the timeline of the service, how it's developed and become embedded within the health system of the West Coast of New Zealand, what works, and then we're going to sum up. So in 2006, myself and some colleagues from the University of Otago undertook a research study. And this was looking at the journey of people with cancer on the West Coast. And what emerged for these people was while their diagnosis was very concerning for them, what was also concerning and causing them a lot of anxiety was actually navigating the system, and not just the health system, but the social care system. So we looked into what was available overseas, and again, we went to the American research around cancer navigation. And we implemented a service in 2007, and it was a 3-year trial, and it was externally evaluated. And Danielle and her team were the navigators who were delivering that service. And the outcome of the evaluation was so strong that we thought, if this group of navigators can have such an impact on people living with cancer, what about those living with other chronic conditions? So we evolved the service into the team looking after people with diabetes, cardiovascular disease, and respiratory disease. And obviously, as time has gone on, they have started to look after people with greater complexity. So not just physical and mental, but also social complexity. And really from 2015, the service became embedded and accepted. So you can, earlier on, we heard from Natalie about skepticism. There was a lot of skepticism about this service. But from 2015 on, the regulated health workforce, shall we say, has really accepted the service, and it is now embedded within the local health service. So I'll hand over to Danielle.
Okay. Thanks, Fee. Firstly, they are local, so they are of and from the community, so they're more likely to stay in the area. And secondly, they know the community, they know the people, and they know the services that are available here. And thirdly, the organisation that we work for has valued us by enabling us to undertake training that is specific to the interest area of each navigator. And as an example, we've done grief counselling, cancer voice training, smoking cessation training, advanced care planning, Treaty of Waitangi cultural safety training, and advanced driving competencies, and that's just to name a few. And the picture on the slide represents the area we cover, and it's very similar to the distance between Auckland and Wellington. Next slide. So, our service evolves all the time, and we try to remain relevant to the local health service. So back in 22, we were still sitting on the Complex Clinical Care Network group and the discharge planning team, and we had an additional 0.5 FTE in the Kawatiri region, or Bulla. Fast forward a year, and our touch point for the CCCN is on the only ward in the newly built Te Nikau Hospital in Greymouth, and that's a regional base hospital. We no longer sit on the discharge planning team, but I receive the admissions and discharge list from the hospital each morning, which enables the team to see if there's any current or past clients that have been admitted or discharged over the last 24 hours, and that they may need us to reach out to them. In terms of the additional 0.5, this is now gone, and the funding that was available for that role was used to give the team members a very overdue pay rise. Next slide. The West Coast is the last province to come on stream for the national bowel screening. So in 2021, the Lay Navigator team won a bowel screening outreach contract. And this was after the team demonstrated how they could socialise the program to eligible clients that they were transporting to appointments. They were a captive audience, you could say. The team provide comprehensive outreach services for West Coasters eligible for national bowel screening, priority populations, who have not returned a kit after active follow-up from the National Coordination Centre. And outreach is provided through a combination of text messaging, phone calls, and face-to-face interactions to encourage and support people in this group to participate. And this is carried alongside our normal workload. So, for example, in the last quarter, July to September, 43 Māori were referred and 57 non-Māori, and the majority, 76, were in lower deciles. And males made up just over half of our referrals. So over this time period, 243 clients have had contact with the service, and for these clients, the navigators have made 399 phone calls, sent 28 emails, had 453 face-to-face meetings, and made 546 contacts on behalf of the clients.
So now we're going to look at activity over time, and I'm actually going to flip between this slide and the next slide. So you can see the activity between 210 and 211 and 220 and 221. Roughly the same, more phone calls in the 220-221 period, but relatively the same. If we go to the 221, 222 and 222-23, you'll see a reduction in numbers of referrals, although the percentage of Māori referred has increased quite dramatically. I'll just go back to the other slide, 10%, 11%. Here we've got 20% and 26%. And the activity has remained pretty much the same with this decrease in client numbers. And this points to the increased complexity of the clients that the service is actually referred. So what does this activity entail? Well, you can see the three main areas up there that the navigators work on. And ultimately, this is what I'd call brokering work. So brokering refers to the work that the navigators do, and it acts as a bridge, either formally or informally, in that boundary space between people, institutions, and organisations. And in the health space, brokering is used to describe those conducting multifunctional work, with particular reference to capacity and relationship building and dissemination of knowledge, which clearly talks to the work that this team does. And ultimately, this boundary work that these navigators, these lay navigators undertake, mitigates the limitations of the current health and social care system within the region. So over the time from 2010 till now, there have been 2 surveys of how health providers rate the service. And I just want to draw your attention to improving access for patients and also improving outcomes for patients. So this is a traditional Likert scale of 5, and this is what the regulated health workforce score the navigators at. So 4.9 in improving access for patients and 4.7 in improving their outcomes. So, you know, they're highly rated by the health workforce, but that has actually taken time to get there. Daniil, over to you. Daniil, you're muted. You're muted.
Barriers and challenges. These continue mostly out of our control. So the ongoing volume of referrals and the complexity of the client's needs will need to be managed going forward. I'm not quite sure how we do that yet. And of course, with the health reforms and the recent change in the makeup of the government here, for us, it's just a matter of waiting and seeing what's going to happen with health.
So I asked Daniil what she thought enabled this team to embed the service within the traditional health service, if you like, so well. And it's great. She had 3 key messages for you all, and that's: ensure your service is responsive to the needs of clients and those who refer to it. Do what you say you're going to do, and complete your tasks in a timely manner. And that will help you gain acceptability of a program. So in summing up, you know, we all know rural recruitment and retention of healthcare workers is challenging, yet this team, 3 of the 4 of the original team are still in place. So we're talking from 2007 to 2023, and that's, I think you would all agree, pretty amazing. The service is now recognised by the regulated health workforce as contributing to improving the health and social care experiences and outcomes of their clients. Over time, the team have expanded their skill set and knowledge and adapted their skills, ensuring that their relevancy continues to those referring to the service, but also to those using the service. And ultimately, this team is the pressure valve within the West Coast healthcare system. So I'd like to thank you all for listening, and yeah, that's all from us.
Thank you very much, Fiona and Danielle. I really liked the way you started to sort of unpack some of the features of the workers, you know, saying that they're of and from the community, they know the people, but then they also kind of know the services. And the other thing that struck me was that point around feeling valued through having that sort of training support that's also tailored to the areas of interest. And I think that's something that we're going to hear about in the afternoon session when we've got Esther Alloon talking about the peer educator program in Sydney Local Health District, that sort of feature of kind of being driven also by the interests of the workers themselves. So yeah, that was really interesting. And again, I feel like we're kind of building on kind of what we're thinking about during the day. So now I'd like to introduce the next presentation, which is going to be a little bit different. So that's great, mixing it up a bit. So this presentation is a facilitated discussion between the presenters looking at what we can learn from the travails of community health navigator programs across the world. So we've got Dr. Sarah Javenprice. Come on up. Yep, come on up. Come on up. Sarah's a research fellow at Flinders University, South Australia, and then we have Professor Sumit Kane from the Melbourne School of Population and Global Health at the University of Melbourne, Victoria. And we've got Dr. Sabuj Kanti Mistry, who is a lecturer at the School of Population Health at UNSW, and he's going to be facilitating this discussion. And we're really happy that you've come all this way to share your experiences with us today. So I'll hand over to you now. You should be able to use those microphones just on the chairs there. And I will put up your...
Thank you, Fiona. Good morning to everyone. I'd like to start this acknowledge the traditional owners of the land where we're meeting today. I would also pay my respects to his elders past, present, and emerging. Community health workers or community health navigators has been an integral part of the health system globally for a long time. While the interventions has been moving on, the researchers, community partners, healthcare practitioners are looking to for good practices, frameworks, and guidelines to have this on a larger scale and learning from it. So with us today, we have these two leading experts in this area when we learn about the travels of community. So on my left is Dr. Sarah Zaban Paras, who is a senior research fellow at the Flinders University. She has been working and extensively working with community health workers program. And she is currently being part of WHO collaborative work to develop the competencies. And in my right is Professor Sumit Kane, who is from the University of Melbourne. He is working in different research projects and community from 4 countries in Africa and 3 countries in Asia, including India, which is actually hold the largest community health workers in the globe. So huge round of applause for this global expert in this area. So this is a kind of conversations where we would like to hear your sort of expertise in international experience in this and what we can learn in terms of how these community health workers would work from Australian perspectives and as a sort of broadly. So my first question is actually to Tara. So we see like in Australia there are a number of roles that is played by community health workers or healthcare navigators. And there is actually, I would say, lack of definition in what the navigators, what are the roles the navigators should play. So what is the international experience? Tell us about this. Why there is so sort of lack of definition on what are the roles they should play?
Thank you for the introduction, Sabuj. I would like to first acknowledge the traditional owner of the land on which we are meeting today and pay my respect to the elders, past, present, and emerging. As Sabuj mentioned, I work on the Iranian Community Health Workers Program for many years. And in terms of the definition, in terms of the definition, I think it's not just in Australia, it's internationally, it's a very broad terminology, the community health workers. And it's an umbrella term that depending on the needs of the population, depending on the context, and depending on the health system and the whole health workers issues, they are named differently and they are doing different activities. And that's why it creates some level of confusion in some countries. But I think it would be helpful to go back to a number of official definitions of community health workers. One which goes back to 1980s from the WHO, that they actually see community health workers as those who are coming from the community that they serve. They are selected by the community. They are responding to the communities for their activities, and they may or may not be part of the health system. So they are part of their community. And this is exactly like the example of Iranian community health workers. I guess it's very close to that definition. So what happens? And the program is like over 40, 45 years old in Iran. And they cover the rural healthcare in the whole country. They are part of the health system, but they are selected by the rural communities. So in the recruitment process, they are nominated by their community and they serve their community. And a research project I did a few years back on Iranian community health workers, I think one of the key messages from that study was that trusting relationship that exists between community health workers and one quote that I never forget when I was talking to one of the community health workers was that in my community, even a patient goes to a hospital and get like visit a specialist and get like some medications for her condition, they never take that unless they come to me and double check with me. So that's the level of trust. So I think going back to your question, Sabuj, in terms of the lack of clear definition, it's basically, it's a very broad terminology. You may not need one definition that applies to all communities. It depends on the purpose of the program. It depends on the community that they serve, and it depends also on the health system and the commitment on this group of health workers. Like in Australia, like we've got Aboriginal health workers, they are well recognized, they are well defined, and you know where and how they stand within the community.
Professor Sumit, do you have anything to add into this?
Thanks, Sabuj. I would like to pick up on Sarah's last point, actually. So we are obsessed with defining things. I think this is an unhelpful obsession. And arriving at a golden definition is a fool's errand. We absolutely should not pursue it. It takes us nowhere. And there is a conflation of things in the definitions that many international how to, the antecedents of, are conflated with a definition. Trusting member of the community, coming from the community. That's not a definition. It's a feature of who you are, what profile you're looking for, and so on and so forth. So building on Sarah's last point, horses for courses, something like that. Huh? So you define the profile you need, you define the kind of cadre one you require. And that might change, that might evolve. And we'll come back to the idea of defining it and why it is important later. But having clarity around that and defining it in that particular context, perhaps more important than searching for that magical one definition. So let 1,000 flowers bloom as long as we look after each and every.
That's great. Great way to describe this. So also in Australia, we see a wide variety in arrangements of how CSWs and navigators are organized and how they are integrated within the formal health system. For example, we see like independents, CSWs working as independent workers, volunteers, or active community members. So what is your experience in terms of from your international outing, how sort of best they are integrated within the.
Yes. So this question of integration, I think the speakers here in the morning have also spoken. Public Health Network is committed to integration of this profile within the Sydney health system. So, I think a prior question is perhaps more relevant. How do we understand this notion of integration? Does it refer to formalization? Does it refer to including them into the fold of a set of regulatable professions? Do we need a whole new cadre? That's a prior question. And I think what I see from other parts of the world is that there is a whole range of possibilities that people have resorted to, mobilized to get this done and to make it work. Now, no matter what it is, unless there are clear linkages, and linkages are a form of integration with the formal, with the frontline health system, no community health worker program, no community health navigator program can work well. And there are a few parts that must be in place. And one, there has to be clarity between what are these cadres doing. That has to be clear to the cadre themselves, but also to the people they interact with. There has to be clarity about what next. And I'm taken back to Daniel's point, the answers to the three questions, right? That people should know what to expect. You should deliver that expectation. I think the public health system's function is to enable and support that to happen. If that is what we are talking about, integration, clarity of roles, clear expectations, enabling all that to happen. Wherever in the world these community health worker programs have worked, whether they have been formally integrated or not, it is this bit that they seem to have got right. And there are programs that went and began well, but then slipped precisely because this did not work out or did not continue to work. Does that?
Yeah, that's great. Yeah. So actually related to these questions of how the navigators are integrated in the formal health system, the question of how they're going to be compensated. So Sarah, if you can light us a bit on your.
I think in terms of their compensation, it depends of how much we recognize them and how much we recognize the work that they are doing. And I totally agree. It's in terms of the integration. I can again give you the example of Iranian community health workers. I think they may be one of the very few models that are fully integrated in the health system. So they are health system employees. They are part of the district health system, and they are paid by the health system. And even for their training, they are paid for their training. So because it's a fully integrated model of community health workers, and that's the way that it works there. So they are compensated and supported by the health. But it might be very different in different, like a review of the different types of community health workers. That was a scoping study that I did in Australia. So there are many different types of community health workers under different names, doing different things that are supported and compensated by different organizations, mainly non-government organizations. And that's the reason that some of them like are they've got some challenges. And the whole debate, I mean, it's an international thing about paid and unpaid community health workers, paid versus volunteering model of community workers, which again, it depends on the level of integration, the type of work that they are doing, the type of organization that's supporting this sort of work and kinds of community health workers. But yeah, in terms of the example, specific example, in Iran, they are fully compensated by the government, by the health system.
Yeah, thank you. And also in relation to that is the training of this specific cadre. So it is really important that how they are trained. But as you know that like there is no established navigator training program in Australia. So what is your opinion how this program can be sort of developed and established in Australia?
I think we've heard a few examples today about training of community health workers or care navigators. That training is important, and there need to be some sort of like formal training for them. It's like pre-service training, in-service training, continuing training, for different sorts of training. And if you look at the training in different countries around the world, the length of training and the content of training is very different. Like in a country like Brazil, you see that they've got like 8 weeks of residential training course followed by 4 weeks of field work. In like Thailand, they've got like a few days of training. And again, it depends on the role and what they are expected to do. Or in country like Iran, they've got 2 years of training. So there are more than 200 training centers just for community health workers. It's residential training courses. So the students go and live in the training centers for 2 years, actually. And they are paid during their training. The trainers should be qualified with a public health degree and have at least 3 years of experience working in primary health care services and networks to be trainers. So it's a very comprehensive sort of training for them, but it's very different in different countries. And a little bit about the current community, the WHO work on training that I'm involved in. So it's the work that just started and it's going to long for the next 2 years. So what they are doing is to develop a competency-based framework for community health workers training and developing training modules for different areas. So it's basically guided by the competency and outcome framework that WHO developed and validated for universal health coverage. And so there are some competencies that all community health workers and care navigators should integrate in their daily activities, like person-centeredness, like decision-making, communication, collaboration, evidence, like personal conduct. So these are the 6 domains on the competencies that every community health worker should learn about. And then there are some activities like home visits or how to communicate with the patients and how to do a needs assessment. So these kind of universal activities that most community health workers and care navigators need to know. And then a third layer would be specific activities. So if a community health worker is only working on cancer or on COVID, for example, so they need to know very specific. So this is the work that WHO is doing, and as part of that, they've done in collaboration with Johns Hopkins University a very like a systematic review of the academic literature, but also grey literature on how training is happening around the world. And interestingly, that I see that there are lots of training modules happening in Canada, in Australia, that is not included in the grey literature review, whether it's not published or whether, and probably my role is that, yeah, it's more than what you found. There's lots of other things.
So lastly, I would ask Professor Sumit about, last question is about the sustainability of this. So what would be your opinion about how these initiatives can be sustained?
We have to wrap up. I think sustainability is a local question. Sustainability is a local choice. And my personal view is, based on the evidence that I've seen, is we should not chase sustainability as understood as the establishment of a cadre for the sake of establishment. We saw in COVID that there was a very clear function to be performed that we were told to be performed. If that role is done, if the function is requirement is finished, then we need to move on. Whether we repurpose the same cadre, the same set of people to do different work is a different discussion. As chronic illnesses become important and a major part of the burden that we face, I would like to think that there is room for a cadre of some sorts which is able to work with chronic illnesses. Therefore, there is a case to be made for a sustained investment in this cadre. Both them, train them, integrate them. No bells, right? Very good.
Well, thank you for both of you joining and coming here to join us today. Thank you.
Thank you, Sarah, Sumit, and Sabuj. That was great. I wish we had more time. Yeah, I really liked that kind of pointing out the need for having context-specific definitions and thinking more about features as well and differentiating features from definitions, and which is sometimes a tension, I think, when we're working within a health system that likes to kind of be able to clearly label and box things, and working out how we do that. Yeah, and talking about compensation, that sort of elephant in the room about, like, how do we do this? And yeah, and that last point from Sumit about sustainability, about being kind of actually really clear, like what we're talking about and what we need to be talking about in relation to that. So now we're going to move on to some more local perspectives. So next up, we've got a presentation, another joint presentation, looking at the programs led by the Centre for Primary Healthcare and Equity at UNSW. So we're going to be hearing from Emeritus Professor Mark Harris, Dr. Sabuj Kanti-Mistry, coming back up, Sabuj, and Kathy O'Callaghan, who works with Herdu and also for the Centre for Primary Healthcare and Equity. And so they're going to be talking about community health worker programs.
Excuse me, sorry, can we just get somebody to open that external door out up the top there? Because that's what that squealing noise is. It's just a bit distracting.
Noise there. Yeah.
Just open. Yeah. No, just open it up. No, oh, is it? That door got closed. Oh, bugger. That's not very good.
Oh, if you push the bar, you can open it.
Oh, thank God. No, it's just that one.
You can't really wedge it open, it's a fire door.
Yeah, just the one.
Okay.
Right.
Okay, so after looking, thank you for all the international speakers. Now we're moving to the national theme and talking about the work within. So we've got talking about the check program, discharge from hospital, bilingual community engagement project, and I'll talk briefly about our community practice in New South Wales. So these are some of the trials, some of the research, development evidence that is happening in New South Wales.
Okay, thanks. I think we've got very limited time, so we'll go through it quickly. And the slides, though, will be available if people would like later. So if there's information on the slides that you can't pick up on, please, they'll be available and you'll be able to get them from us. This is a study which involves a lot of people. It's a partnership between not only the University of New South Wales, but the Sydney Local Health District, but also the Central and Eastern Sydney Primary Health Network, the Health Consumers New South Wales, and ACI, the Agency for Clinical Innovation. And as lots of investigators and collaborators and a really important research team there, as well as various members of the Plan Care team that are involved in the project. The aim is to develop, implement and evaluate the impact of community navigators delivering a model of care that supports a transition from hospital into the community, and particular focus on those who are aged or who have chronic conditions. We're interested in their broad range of outcomes, including readmission. We conducted a co-design phase, which was quite lengthy. We had all sorts of interviews and workshops, and this was analysed and really shaped the development of the project and how it's been implemented. The community navigators have been recruited and inducted into a training program, which has been both online and face-to-face, largely coordinated by Liz. This is a program which was modified from a training program that we've been using that Sabush will talk about with the navigators in general practice. The model of care involves the community health navigators following up patients within 72 hours of discharge. And the focus is on building patient understanding and confidence, identifying problems and in the living environment, particularly social isolation, checking on medicines, because this is a common reason for patients running into difficulty post-hospitalisation and a common reason for readmission, either that medicines aren't taken appropriately or and so on, or they don't get back to their GP to receive continuing prescriptions of those medications, and monitoring self-management. And then in consultation with the rest of the Plan Care team, working out a plan for what needs to happen. So this is a bit different from a care plan. This is not a clinical care plan. This is a plan for what needs to happen to solve some of those problems that have been identified, and then following up by telephone and further visit if necessary, and ensuring that patients get to the services that they need, particularly their GP for continuing medications, their pharmacist, allied health providers, and so on. So we're evaluating this in terms of the impact that this has on hospital readmissions, but also adherence to medications, quality of life, the changes in their understanding of particular aspects of health and the health services, their assessment, their experience of having chronic illness care, their change in the pattern of use of services, including GP and ED services, and the overall experience of healthcare. Where we're at is the trial is currently proceeding. There's a whole lot of steps to go through before we could start the trial, including the training of staff and the research staff involved and getting them accredited with the hospital. And then we're currently at the phase of patient recruitment and randomisation, doing the baseline data collection, having the patients that are in the intervention arm receiving the Community Health Navigator follow-up, and those in the control arm receiving usual care. So what have we learned so far? There have been some successes. The training, the selection and training of the CHNs has been a success. We've had strong support from senior management and acceptance by the health service staff, including the rest of the planned care team, and interest in developing the role from other local health services and programs. Some of the challenges have been challenging to ensure that other staff within the LHD are aware of the projects. There's a lot going on in Sydney Local Health District. Those of you who from Sydney Local Health District will understand there's lots of special programs, including a number of programs for following up patients post-discharge. There's different perspective on the role of BCN. So again, developing some clarity and consensus around exactly what they're to do and not do and for how long. For example, how much they engage with things like working with My Aged Care, the Commonwealth program for elderly people relocated into the community. There's been turnover of staff, both amongst the planned care and amongst the BCNs themselves. And probably the most acute problem is we've had quite slow patient recruitment. This has been our biggest challenge and the thing that we're trying to do most about. And there's also been an issue around the supervision of the community health navigators and how that's arranged and providing them with adequate support. As Fiona said this morning, this is a key issue for community health navigators more generally. I'm now going to hand over to Subhuj.
Thank you, Mark. First of all, a little bit of clarification in information. So I submitted my PhD thesis, obviously, but it's my conferral of PhD still to happen. So I'm yet to be doctor anyway. All right, so this research was aimed to explore the feasibility and acceptability of involving bilingual community navigators in general practice setting, and to help better access patients from the culturally and linguistically diverse backgrounds. So this research was carried out in 5 practices in Sydney, where most of the patients spoke a language other than English, and mainly in the Bankstown Yagoon area. So, and we followed a multi-phase mixed method design, started with the needs assessment, where we sort of undertake qualitative interviews with some of the practice staff, which is followed up with co-design exercise with different stakeholders, including patients, the caregivers, healthcare providers, researchers. Then followed up with is implementation of the developed interventions through this process and exploration of the feasibility and acceptability. So as I said, based on the first 2 stages of the research, we developed this model of care where navigators are to be based in the general practice. Patients would come to the practice, have consultations with the GPs, and based on this conversation, GP would identify their navigation needs, which and they refer back to the navigators. Navigators comes in contact with the with the patients, discuss their problems to access services, and provide necessary services through providing healthcare education, emotional support, or booking appointment, or whatever services that is needed to have better access to the health services. So we recruited 12 community health workers from 5 culture groups, which is actually the 5 practices that that took part in the first phase of the interventions, who received 4 hours of face-to-face training and 22 hours of online training program that Mark has already mentioned we developed. We approached all the 5 practices who participated in the initial phase of the research, but 2 practices finally consented to take part in the intervention phase. And we placed 3 navigators who are trained to these practices for 10 weeks. They would sit in the practice for 2 sessions in a week, each lasted for 3 hours. They were also allocated an additional 2 hours each week if they required anything to do besides their allocated 3 hours, 6 hours per week. As part of the role, navigators would fill up our logbook where they would provide, would sort of fill up the background characteristics of the patients or the services each of the patients received from the navigators, which we later analyzed quantitatively. We also have undertook post-intervention in-depth interviews with 16 participants, including patients, their caregivers, navigators, and practice staff. Which we then analyzed qualitatively to understand the feasibility and acceptability of these interventions. So finally, 95 patients were served by these navigators from these 2 practices, and they helped the patients through to better access the services through booking their appointment with the specialist services, identify the local resources, navigating the services. Most patients had actually 1 encounter with the navigators because of the short time frame of the projects, and the average appointment time was about half an hour. So overall, we found this intervention was very much feasible and well accepted by the patients and practice staff. Felt need for the services as well as the acceptance by the patients, recruitment of the navigators from the patient's own community, and trainings and motivation for the role amongst the navigators was the main facilitators for effective implementation of these interventions. While most of the patients and practice staffs accepted these interventions, there were a few sort of barriers also been identified by the participants post interventions, such as there was a lack of awareness to some extent among the practice staff about the navigators roles. So we could have done more sort of mobilizations of their roles in the practice. There is also unavailability of the information about the local culture specific services. There is no such database as mentioned this morning by Simone about 211 or something like that. So this is probably a next step to develop something like this where navigators could take the help, take the information and guide the patients towards. There is also inadequate time for the patients. There was flooding of patients. Particularly in some cases, and navigators have not had enough time to address all these things. So there are some key next steps. So as already mentioned by speakers in the morning, that we received some further funding to sort of, thanks to CESPAN for allowing an extra funding to sort of extend our interventions to some other practices to see how it works in other contexts as well. Other projects are also in development in communities with gambling problems and refugees in general practice as well. We also need to have this training program revised for the larger scale based on the feedback, consultations and comparison with other programs. And there should have a sort of long-term organizational base for this training and accreditation of this Navigator program itself, because the university is not actually the right place to accreditation and having a long-term commitment in training. And obviously, further research need to confirm the effectiveness and its cost effectiveness to actually claim that, well, this is a cost-effective interventions and we need more sort of effort in this. So that's probably all I wanted to say. Thank you.
So just briefly, we have a community of practice within New South Wales to support the community health navigator worker roles and practice, of course. So the 3 domains are really people who have a common interest and a passion for working in the area.
and then building the community and sharing ideas, collaboration, and that collective knowledge that people come together within our community of practice, and then actually developing resources and training and events like this to bring forward the work. So the aims are really to share knowledge, experience and learning, to bridge evidence and research to practice, integrate work into policy and future research, and support accreditation, training and ongoing support of community health workers. So the group has been involved within the Centre for Primary Healthcare and Equity, and a lot of people here today are involved in that. So South Australia, Victoria and internationally to hear what's happening in different areas. And a key component of this is really action items and goals. So working towards future research and grants and projects and really to build that evidence. And we've been meeting since 2019 and reviewing models of care, as I said, in local health district representation and reviewing national training, accreditation and support and models. So yeah, if you're interested too in being part of this practice, the important thing is to meet regularly and so in December. So yeah. Thank you.
Thanks, Kathy. So yeah, I think if anyone's interested in becoming involved in the event, Kathy. All right. That was great. I think what really struck me about that presentation was getting a sense of the breadth of work that's going on, and also the value of having these like long-term partnerships between academics and local health districts and PHNs that kind of enable this work that this is kind of work that takes time and then it also builds over time, and so being able to have those kind of long-term partnerships I think is really key to that. So next up, we've got another local presenter presenting a sort of New South Wales perspective. We've got Professor Sue Wolfenden, the Director of Community Paediatrics at Sydney Local Health District, and she's also Professor of Community Paediatrics at the Central Clinical School at the University of Sydney. So she's going to be presenting on co-designing social prescribing pathways to address health inequities of children with cerebral palsy and their families. And then when she's finished presenting here, she has to rush off to the Children's Hospital in Westmead to do another presentation. So thank you very much, Sue.
Hello. Kathy, in the meantime. Yes. I've got it on a USB.
Okay. How about you just start talking and we'll
I'm Sue Wolfenden. I've been introduced, and I'm going to talk about social prescribing in child health, specifically around children with disabilities, but really, cerebral palsy is a chronic disease. It's a disability. This is a good exemplar for any other chronic disease. And I'd like to acknowledge the traditional meeting, and I would say that a lot of this work has been basically, I think for me as a community paediatrician, where we're so used to working with NGOs to get support around the social determinants for our families. For me, becoming a researcher, it's really been about how do we systematise that? How do we show that what we kind of know clinicians can work on a bigger scale? Good to go? I definitely got it on USB. Do you want me to grab it? Yeah. And I think the voice particularly thinking about a really powerful welcome to country this morning. Really always thinking about this from a strengths-based perspective. None of the families that I work with, either the Aboriginal families that I work with, Peru's for a long time, or here, or any of the culturally and linguistically diverse families that I have the pleasure to work with, and kids with disabilities, no one sees themselves as vulnerable. In fact, I think they're incredibly resilient people who have to deal with an incredibly fragmented and difficult system. I deliberately call them priority populations because of that, because it's our priority to really think about how do we design our healthcare and our social care systems so that we're seamless with families. And a lot of this work came because we had families saying nothing on Google just trying to find services. So I'm going to talk about why you need to co-design social prescribing pathways in paediatrics. So this is some research that basically shows something as sort of biological as you like as cerebral palsy has inequities. So, you know, cerebral palsy is an injury to the developing brain. Lots of pathways through. It has sort of three major severe outcomes. One is whether you're ambulant or not, whether you can walk. The next is whether you have an intellectual disability, which is around your learning. And then comorbidities such as being deaf, blind, epilepsy and non-verbal. And what you can see here is a beautiful social gradient. I don't think I've got a pointer. But you can see a social gradient, basically, where what we've looked at is outcomes of children with cerebral palsy on the Australian Cerebral Palsy Register. And we've looked at kids by their postcodes. The dark blue line are the kids living in the lowest SES neighbourhoods, and the light blue are in the highest SES neighbourhoods. And you can see for being non-ambulant, not walking, for having a significant intellectual disability or a significant comorbidity, the wealthier you are, the less likely. No surprise at all. And we also found that for minority ethnicity mums as well, and for young mums as well. And the question that was asked of me when I showed this to Nadia Badawi, who's a professor of cerebral palsy, is, and what are you going to do about it? And I do think that that is something that we as equity researchers really have to now think about, is we can't just sit back and admire the problems. And I wonder if social prescribing might be a way as individual clinicians we can do something. I'm all for a civil society, and I think that's an argument we sometimes get against navigation is, can't we just wait till the world's fairer? I've been waiting a long time. And I think we kind of need to do stuff in the meantime, and potentially the social prescribers can help us strengthen our systems as well. So, then there's a whole issue of should doctors be treating social determinants of health? Now, in community peds, we accept that that's part of our role, it's part of our training. So I always flip this up for the more specialty pointy end people. I remember that I do not treat a fever chart, a cancerous growth, but a sick human being whose illness may affect the person's family and economic ability. My responsibility includes these related problems if I'm to care adequately for modern Hippocratic oath. Great Michael Marmot, Physicians are Advocates for the Poor. And we've got a number of position statements, including our own at the Royal Australian College of Physicians, but also the American Academy and the British, that says actually part of our role in addressing inequities is we as clinicians, when we see a family, we need to think about how we treat them. And so my question was, well, how do we do this for cerebral palsy? What's the evidence? So we did a systematic review in Sydney Local Health District with Sydney Local Health District staff and also the wonderful Shanti Raman. This was just an advanced trainees project. I didn't have a whole bunch of researchers doing this. And we basically had a look in the literature and said, what are people already doing in terms of paediatric social prescribing, being some kind of systematic identification of unmet social needs and then some kind of response to that, because we don't want to be screening it if we're not going to do something about it. And the Americans have been doing this for ages. They actually have it as part of their Affordable Care Act that you screen for social health in your clinics. We found basically lots of studies, can't remember the total off the top of my head, I think there's about 12. The majority, 11 of them were in and in the US, and one was in Canada. And essentially we had, we had about 8 randomised controlled trials, but there's the reference for you. But basically there were 3 types of intervention. First intervention, you train your, you have some kind of standardised approach for identifying unmet social needs and you give people a resource. The second type is you have some kind of standardised approach and you give them a navigator, either in person or virtual. And the third bit is you train your residents in how to identify unmet needs. And basically all of those result in a greater identification of unmet social needs and a referrals for it. There was sort of mixed insufficient evidence around child health outcomes. There were some studies that showed they improved and some that showed there was better access, but they just hadn't quite got there. There's no trial evidence that I can find in Australia, so if anyone knows of any for PEDS, please let me know. And there's certainly no trial evidence globally for so that's what we decided we would try to do. So the EPIC CP project has two arms. The first bit, which we've completed, is the formative design, where we've worked with families, service providers. You've got to have them in your co-design, otherwise they're not going to do it for you. Service providers, we've had young advisors with cerebral palsy parents who have been with us the whole way. And we've been working with the tertiary paediatric rehab services across the state to do this, but I could do this equally in general paediatric as well. And I'll show you what we've co-designed in terms of the pathway. And the reason we did this is because we didn't know how to do it. And I'm really glad we did it because it made it really hard then to actually implement it as in the trial and also to get the ethics through. And now we're at the pilot feasibility trial. And Mark, I do agree that the RCT bit, individual RCT, may be a bit of a tricky way to actually look at this, but it would be good to get high-level evidence. So this is our screener, if you like. It's adapted from a tool used in the US. There's multiple tools you can use, but this one I really like. It's called the We Care. And what I also like is that Arvind Garg, the guy who's designed it, is just a lovely man to work with. And so essentially what we do in this is we say children and their families thrive when their parents and carers are supported. Our service can help families connect with community resources and provide support. Many of these resources are free of charge, and we know that. There's lots of NGOs doing lots of stuff for families. And we're just saying, would you be interested in doing that? And we can give you some support. And then we spend a lot of time going, how do you ask this question without offending people and without it all being sensitive? And one of our youth advisors is a young man with intellectual disability, and we're all faffing around with the words need and this and the other. Just said, just ask them, do they want help with? Just do that. So we went with, do you want help with childcare or schooling? And we've got the easy read kind of symbols as well. Government benefits, vouchers, housing, food, bills, transport, and using the NDIS, which this is what we did in sort of our QI approach of the co-design. And we've got to prefer not to answer, which I think we've now changed to maybe later. We then have red flags, because clearly we're working with the social workers in the we're like, whoa, hang on, what are you doing here that's not going to be already done by me? And our point was that we saw this role as more like all the kind of bureaucratic stuff does people's heads in about which form to fill in, more like a concierge, and that anything that was therapeutic would be with the social worker. But we also had red flags there. And then we asked people how comfortable they were in actually. I think it took us all about 5 minutes, and we said to people, would you like, we gave them a free information pack, a resource pack of services using Ask Izzy and local knowledge, and then we said, and would you like anyone? So this was in the sort of QI process for formative design. And we did think that we could get our doctors to do this in the actual clinic, but both the doctors and the family said to us, no, not in my clinic appointment. It takes us 6 months when we have so much to get through. Please just do it in the waiting room, but we want the person who does it to be the person who now we debate whether it's an admin person. Everyone gets a resource pack. It's hosted on the Kids Hospital site. What's nice is that it's also, you can press it and listen to it. It's translatable. And essentially we've used Ask Izzy to help us find that information. So every family gets this as well. And this is just from our QI approach, and then I'll talk about the RCT. So in the formative design, we just thought we'll just test this out on 127 families who came to Westmead's CP clinic. And what was nice, 83% of families were happy to complete it. 65% of families had one or more unmet need, which kind of shocked me a bit. Didn't shock anyone in our advisory group. And 44% of, about 40% of families had 3 or more unmet. 76% of families were very comfortable, and 74% a call. And the most common unmet social needs was not the NDIS, which is what I thought it was going to be. And that's probably because clinic addresses a lot around the NDIS already. It was government entitlements, and that has stayed the winner in this current RCT as well. People do not understand sentence. They do not understand transport, and then the NDIS in the trial, in the thing. Moving along. So what we've got now is a participant-patient journey. All right. highlight all my technical issues. So we have the standardised identification at the beginning. Then we have people coming into our EPIC CP program. So this is going to be our intervention arm. They are linked with the linker. The linker is an allied health assistant. They already work in the rehab departments. That is our sort of sustainability link. They kind of do this anyway. It's about standardising what they do. And we have standard operating procedures for allied health assistants. I'm going to be looking at everyone's training program and talking to Kathy as well about how we do even more with that. And this is just from one of our people one of our parents who's, we have research advisors who've now become co-investigators on this research. And this is from Mass, who gave us permission to just give you this quote as to why we have to keep going with EPIC CP. Living with a family member who has quadriplegic CP and high needs, you need to learn the simple things in life. The everyday things a person needs to live on, like transport, house, food, paying bills. Fight for your rights. You have to fight bureaucracy. You have to fight just to have any quality of life. You even have to fight for your own mental health. Never give up and go through it. We need EPIC CP to succeed and for stakeholders to understand the enormity of the issue. So I always have to have that posted on the front when I'm feeling like I'm the only person doing social prescribing, which I don't anymore because I found my friends. And I just want to say a big thanks to our young adult research advisors and parent research advisors, the entire team, which is clinicians, Aboriginal research leaders, disability advocates, and obviously our funders, our two universities. Thank you very much.
That was amazing as I like the way you flip the narrative, at the start, drawing attention to the difficulties in navigating the system and the resilience of people who are having to do that, and giving us a really clear call as researchers to move beyond describing the problem and thinking about what to do about it, and really clearly also, explaining how social determinants it's within the remit of health services. We need to be thinking. Yeah, so now we've got one more presentation before our lunch break, where I think we're going to have lots to talk about. So our final presentation for the break is from Victoria, and it's another example of collaboration through a joint presentation, and I'm sure in terms of the work they're doing. So we've got a hybrid presentation, so online and in person. So we've got there's Sue Wicker, the project manager for the Health Navigator projects for the Staying Well program in Northern Health Victoria, and she's going to be joining us online today. And then we've got in the room, we've got co-presenters Dr. Rebecca Jessup, the Director of Research and Evaluation for the Staying Well program, and Sian Slade, a PhD student at the University of Melbourne in Victoria. So they're going to be presenting on the Navigator programs that they're involved in, and I'll find their presentation. Or are you sharing it online?
I'm presenting on behalf of myself and Susan. Thanks for having me today. I'm so excited. I feel like I'm in a room full of people just like me, so it's really exciting. But I also wanted to commence by acknowledging the traditional owners of the land, the Gadigal people of the Eora Nation, and pay my respects to their elders past, present and emerging. I want to acknowledge that sovereignty was never ceded, and I am personally very sorry for recent events that have caused pain and suffering. I am very excited to share the work that we are doing at Northern Health, in partnership, a lot of it with the Department of Education and Training in Victoria, Swinburne University of Technology and Medibank Private. And I would not like to acknowledge my really awesome team, most of whom I think are online. So Susan, Simone, Natalie, Lubab, Wadid, Lichka or Lish, and Chacha. So hopefully they're watching today. So we've been working on our Peer Health Navigator work for almost 2 years now, and I'm hoping most people in the room have seen the policy brief that the WHO brought out last year on patient navigators. And it's a great brief to hang your hat on, because it talks about how existing programs globally are showing a lot of success in this area in improving equity gaps and engaging communities, but that the contexts vary a lot between countries, and this context means that we can't always translate the findings from other countries to Australia. And as we've heard over and over again today, we don't have enough evidence in Australia that these roles are effective, and we're trying to all work to build that evidence. But we do need to build that gap, work on that gap. And one of the other gaps we have is obviously around training. How do we train these individuals? And that's one gap that we're trying to address in Victoria. So we're working across two key streams of work at the moment. We're actually developing a Certificate 3 in Community Services, in brackets Health Navigator, which is informed by a capability framework that we're developing. And then we've also working on another piece of work where we've been co-designing and planning to trial and work on a scaling up toolkit for hospitals for new Health Navigator roles. So just to moving. Okay, so we're in the process and we do have, it is in draft. Simone, one of my co-workers, has been working very diligently on this piece of work, but we're developing an Australian capability framework for health navigators, and it's based on a systematic review of skills and attributes related to the training of lay navigators internationally. So really interested to hear that the WHO are doing this work as well. And on existing international capability and competency frameworks. And we've also done a lot of work nationally, running focus groups and interviews with consumers, some of whom have received assistance from navigators previously, some of whom have just got complex and chronic comorbidities that would benefit from a navigator. We've worked with health professionals, subject matter experts and academics, and employers and managers of health navigators to really try to understand what the skills and capabilities are for these individuals working in these roles. And why a capability framework rather than a competency framework? So capability is a description of the skills, knowledge and tools that are required to get the job done, whereas competency is about measuring those skills in the workplace. So I think we need both. But right back to basics, we need to work out what the skills and attributes are, and some of them are teachable and some of them are not. So we need to recognise what are the skills that we want people to bring to the role before we actually add any additional training to that. So as it stands, our capability framework actually consists of 4 key areas. So the personal attributes that someone will bring to the job. So things like empathy, and I know there's been a bit of debate about whether empathy is actually teachable, and there is some literature to say it is. But we want people who are quite empathetic to come to the role with those innate skills. Trustworthiness and a people person. Someone with tacit knowledge and skills gained through lived experience. And that would be really job dependent. So at the moment, we're very focused on bicultural peer health navigators. So we're looking for people to link individuals in with their community, their cultural community. So having that cultural background, having the language, all of those skills. There's the formal training, which we can teach, the teachable teaching, we call it. And then there's organisational responsibility. So, and this has been touched upon quite a bit this morning, making sure that we can provide adequate mentoring, supervision, and competency assessments for navigators. And this is our in-draft capability framework. And then there's the formal training that we've been working on. So this is the content of Certificate 3 in Community Services. So it's quite a complex thing what we pitched to government initially was we wanted to write a new training program for health navigators at a TAFE level qualification. And government came back and said, no, it'll take years and years and years to get approval for a new training program because it's got to go through a really arduous accreditation process. what we'd like you to do is contextualise an existing qualification. So we had to do a review of the existing Certificate 3 qualifications and look at what would be an appropriate fit. And with the qualifications, you have a number of core modules that everyone has to do, and then you have a number of elective modules that you can choose from. So these are the 5 core modules that make up the Certificate of Community Services, Certificate 3 in Community Services, as you can see. And this is the 7 additional modules that we chose based on the capability framework research that we were doing to back it. And I'm really happy to share this information with anyone who'd like to review it. And we've spent a little bit of time with Liz looking at the training package that they've got for their navigators, as well as working with Peter Mack and Jerry. Someone mentioned Jerry this morning, who did the Churchill Fellowship travelling around the world. And we've done a lot of checking back to make sure that we're on the right track. And the feedback we're getting is that the qualification seems to fit okay with the skills. The other bits of feedback we're getting is that we probably need to look at a Certificate 4 with more specialised skills for people in navigators working in particular areas. I've had another malfunction. There you go. Maybe just pull the drawer out. Go back. And the other thing about these, each module, is that it will also be a micro-credential, so it can be picked up individually. The individual who completes it obviously won't have the full qualification, but in working with Medibank Private, they have health coaches that they felt would benefit, who actually have professional qualifications that would benefit from doing individual modules to help them with their work. Okay. And Stream 2, which is our co-design of Health Navigator roles. So we work in an area that's very diverse, very similar to Sydney Local Health District when Luann was describing it this morning. We have over 185 languages spoken in our region. We have over 90 different religious or spiritual beliefs identified in our community. We chose Arabic speakers, which predominantly come from Syria and Iraq. So we've got a big population of refugees from Syria, the largest in the Victorian area, and we also have Lebanese and Egyptian. So that it's the second most spoken language in our region, but I'm recognising that even though they share a language, they're a very diverse community in and of themselves. And we also chose the Pacifica community. We felt that they're quite an invisible community. In our data, they're really invisible, but their health outcomes have been really poor. So during COVID, the Arabic-speaking and the Pacifica community were they had the worst outcomes in our region, with mortality rates up to 80 times higher than Australian-born. So, and I'm not kidding, 80 times higher for Pacifica community, particularly the Tongans, and 13 times higher in the Arabic-speaking community. So we realised we just didn't have any reach. They weren't getting vaccinated. The communities weren't getting vaccinated. They didn't trust the health service. They were accessing care late. So that's why we've focused on those 2 communities. And we've run a series of 4 co-design workshops with communities to identify what their barriers to care are. And interestingly, even though they're 2 quite different communities, their care issues, their barriers are the same. And this is just hospital-based barriers. We weren't looking at community-based barriers. So ED was like a big issue, and lots of things coming up in workshops like, we are so sick and we wait so long and we don't understand why, because when we're in Syria, when we go to the ED, we pay for care and we get treated straight away. And if you arrive in an ambulance, you always get treated straight away. So the care here is really poor because we have to wait so long. So there's a real lack of understanding of how risk is identified within the ED and how that's managed. Inpatient support, particularly for people who are experiencing isolation. And it's been interesting talking to our language support services who say, we think we do outpatient clinics really well because they're booked appointments, but in inpatients, if you're alone and you don't have family who can speak your language, we might be there for your ward round in the morning, but then otherwise we won't provide you with any support during the day. So these people are sitting in beds having no idea what's going on. And there was lots of talk about group-based care. We'd like to come together with other people from our community and receive care together. And there's a lot of evidence for that in antenatal care. This is a really busy slide, but I also work with the Victorian Virtual Emergency Department, which is a statewide virtual ED, and you can self-refer into that. And just to demonstrate that actually what we're hoping to do in our next phase is actually help to redirect some patients from the face-to-face ED into the virtual care ED. So we actually have a model where we can provide an alternative if they're the Category 5 presentations, so they're suitable for seeing a GP. So we've kind of brought our two pieces of work together because, funnily enough, everyone we ask is coming up with the same answer. We want health navigators to help us to access care at the right time, in the right place, and the right type of care. So we're proposing 2 trials. One will be in the ED, as I said, redirecting, and also just helping provide some understanding of why the wait is what it is. We are initially looking at 72-hour readmissions as our primary outcome, but we're really interested in wait times within ED, whether or not we've actually been able to impact on that, as well as obviously patient satisfaction. And we also want to look at whether or not we change their use of health services across the board. So if we do some digital health navigation training, this is how you use the service. Does it change, does it mean that next time they use that service from home, which actually is much better for them than coming in and waiting in an emergency department? And then we're also looking at the inpatient space. So actually providing care for people when they're on the ward. We think it may actually impact on length of stay, because what we're hearing in these co-design workshops is we often don't tell doctors and nurses what's going on for us at home because we don't feel safe to do so. But if there was someone who looked like us and sounded like us, we would automatically feel like we had that relationship of trust and we could share that information. And so providing that care in inpatients, and then within 7 days when they get home, but no longer than that. So it's actually very much a hospital-based intervention. We don't want to replicate the great work that's being done up here in New South Wales. And that's it from me, and this is my awesome team, or some of them.
Hi, everyone. Thanks very much for having me. Thanks very much, Liz, for inviting me to be here today. I'd also like to pay my respects to the Gadigal people and acknowledge people who may be attending this meeting, as well as elders past and present. So my name is Sian Slade. I'm based at the Nossal Institute for Global Health. I'm doing a PhD, which is an international PhD, looking at navigation. The countries that I'm comparing are Wales and Australia. Very happy to have a chat with people about my PhD, but I am working with a PHN, so I'm working with South East Melbourne PHN as part of the South East Metro Health Service Partnership in Victoria, and working with Welsh Government, partly because of their focus on value-based healthcare. And many of you have met with Sally Lewis, who heads up that work. So I'm coming from a slightly different angle to the previous presentations. I came into academia from a corporate career. I'm a pharmacist, clinically trained, but I worked in the global pharmaceutical industry for 20 plus years, mainly building capabilities, mainly in R&D. Now, what that taught me was around change management and really sort of understanding scale and sustainability. And I completely take Sumit's point that as soon as you've reached sustainability, you're not sustainable. So I think this is sort of something that we sort of work through. But some pivotal moments about why I came to do a Masters of Public Health and now PhD at the University of Melbourne. So I worked in HIV/AIDS many years ago in the 90s, and I worked with lots of patient activists who worked with politicians, policymakers, healthcare professionals, change the system. And they changed the system not just for me in the UK at the time, but they changed it globally, and also worked with people from low middle income countries who were coming into the UK to make sure that there was a real focus on equity. So I have used that to guide my career throughout in terms of why I do what I do and why I know what's possible is what's possible. And in fact, 30 years ago, I was telling Rebecca as I came here, I actually qualified as a pharmacist here at the RPA. So I did my forensic exam here at RPA many years ago. So this is the first time I've been back, which is wonderful. And then went straight into that job in the UK, basically working in HIV/AIDS. But a couple of other things to tell you. In between times, I've led global knowledge for Bristol Myers Squibb. So this was really around how you bring countries around the world to sort of come together with a common theme. And then lastly, why I got into this was I saw one of my friends 10 years ago diagnosed and navigate pancreatic cancer. Despite being a nurse by background, highly health literate, found the system different to what she may have anticipated. And I guess no more complex than this. I sort of thought the standard that you walk past is the standard you accept. I think I've got the requisite skills to have a go. Found some fabulous supervisors at Melbourne Uni who agreed to take me on for a capstone and now for a PhD. Mindful of the bell, I'll just whiz without whizzing. Helps. And this really echoes a quote that Sue put up in terms of navigating the system. And, many of you will identify with this, but I'm going to sort of walk you through the words. And it literally is your life in their hands. You listen and try and take on board a lot of information that is given your way, some of which is ambiguous, some of which is contradictory, truly an anxiety-provoking time in one's life. This was a gentleman in his 60s who'd run many thousands of people in teams in terms of what he was doing and was facing his own situation and recalling what that felt like in that moment. And, these are the stories, quite frankly, that compel me to action in terms of why I do what I do. And a bit like Sue had said, if ever I think, gosh, I'm trying to take on something that's too big here, I just go back to the why. Hoping this is going to work. Not. Sorry. What's easier for me to press? Okay. So one of the conversations that I had right at the beginning is, where do you even start? I came into academia from a corporate background, clinically trained, yes, but coming into this and really understanding what is it, where do you even start? I did comparative health systems as part of my MPH, loved it, taught me about that actually most stuff in the world has been addressed. It's just that you don't necessarily know because people are working in different camps or different silos. So I guess the